is we're trying to look at how trust is, or better understand how trust is established in the emergency pediatric setting. And basically this is the collaborative team that was put together by Elena and Dr. Ponaru. And so we, based on the current literature and what's been done by Dr. Ponaru and others that have been working on this to date, we know that trust is an essential component of the therapeutic relationship between patients and their physicians. It's found to improve patients' willingness to seek medical care, disclose information, and generate overall positive psychological impact. So we know in settings such as family medicine and in more outpatient care where, the patient regularly sees the healthcare provider, it's easier to establish a more trusting relationship when there's longitudinal follow-up. But in situations, in acute situations where let's say the child presents to the emergency department for requiring an emergency surgery or for a medical procedure that's urgent, there's not a lot of opportunity to establish a connection between the physician or surgeon and the patient. There's also a recent scoping review done that indicated that parental trust has been correlated with overall physician competency, communication, dependability, and caring. So there have been studies examining kind of the elements that contribute to the development of trust, but there hasn't been a study that has examined how trust is established between parents and physicians, specifically in the emergency pediatric setting. So that's what we're going to be focusing on. So the objective is to explore trust in the urgent pediatric setting, and that includes in the pediatric surgery and in the emergency department. So after several meetings and some discussions, we would like to proceed with a single center prospective mixed methods study that will be conducted at the Montreal Children's Hospital. And the study population will include parents of children being treated for urgent medical or surgical conditions. The recruitment will take place in the emergency department. Now, we haven't decided exactly the logistics of this recruitment, and there's been some work done on using QR codes for parents or patients to scan and to complete on their own time. I'm not too familiar with kind of the success rates of using QR codes versus parents filling out the surveys and questionnaires physically in the emergency department. So we still have to refine that strategy. And essentially we want to collect questionnaires that examine the trust component. And a little bit later, I'll show the 2 validated trust questionnaires that have been used in previous literature that we'll have to determine whether we want to use those or come up with our own survey to give to our study participants. And then we want to essentially use the data gathered from the surveys to better inform a semi-structured interview process or focus groups, which will be analyzed by either an interpretive description methodology or the grounded theory framework. And to be honest with you, I haven't done enough research into these two methodologies. So I still have a lot of work to do in terms of understanding what will be most appropriate, and of course, asking the appropriate individuals to help with that element. This is basically the grounded theory framework that we may use, and it's just outlining kind of the process of using the data and the variables of interest from our questionnaires, and then using a purposive sampling method to recruit a sub-sample of the parents that fill out the trust questionnaires, and then doing our semi-structured interviews, and then doing the coding process and actually analyzing the qualitative data to support the quantitative data. So ideally, this is the schedule of events of the study. So we would be consenting we would be consenting parents of these patients in the emergency department. We'd be gathering patient demographics, also parent guardian demographics, the medical surgical history, what procedure or reason for visit, inclusion exclusion criteria. And then we would do the trust questionnaire or survey that we come up with. And then we would do the semi-structured interviews or focus groups, depending on what we decide. And this is kind of the main question I have for you guys regarding the selection of the questionnaires. So there's a questionnaire called the Pediatric Trust and Physician Scale, and it's based on a validated tool to measure adult patient trust in a specific physician. So this is just an example of the questions that it asks. And then there's also another trust questionnaire that was validated in 2014 for colorectal cancer treatment for decision making. And unfortunately, I don't have the original questionnaires yet. I've emailed the authors of these two papers, so I'm waiting on those. And then my plan is to circulate the two validated questionnaires to the study team, and then through a process, we'll figure out which questions to use, or whether we just want to use one of those for the quantitative component of the study. So Dr. Pornar, I'm not sure if that's still something you would like to go ahead with. Yeah. And yeah, that's basically it. So there's still a lot of work to be done. Again, this is just a quick progress update. My plan is to have the protocol in the second revision stage by next week. And then I'm slowly filling out the ethics, the Nagano ethics REB portal. And then I guess we'll go from there, but it's still very preliminary stages in terms of methodology and refining the first phase, which is the survey phase, the quantitative phase. And that's the first step of the study. And then once the surveys are completed, and I mean, this might be too ambitious of a timeline, but we'd like to complete the surveys first and then base our qualitative component of the study on the findings from the surveys. And then there's further qualitative components that we can do as a sub-study, but I won't go into details on that today.
Okay, so good afternoon, everyone. I'm Marina, and I will be presenting a paper the team and I have been working for a while now. Before I get started, I will tell you a little bit about myself. So I am currently finishing my bachelor's degree in pharmacology with a minor in psychology, and I plan to continue my studies by doing a master's and a PhD. So I started working on this project this summer after I joined the Commissar Lab. And after many meetings and many modifications, it seems like the paper is finally about to be finished. Today, I will be presenting the evidence-based mismatch in pediatric surgery, do as I say, not as I do, which puts to light the gaps in evidence-based medicine being practiced today. So what exactly is this project about? Most elective pediatric surgical procedures are generally considered safe and are based on factors that define the patient's best interest and the surgeon's expertise. However, surgeries for non-threatening conditions have limited morbidities, but surgeons are forced with a significant parental concern driven by the spread of misinformation. While surgical intervention may effectively address these concerns, would simple reassurance and effective follow-up suffice? So before I dive into the paper, I think it's important for everyone to understand what evidence-based medicine is. Evidence-based medicine proposes that clinical decisions should be made on the basis of trustworthy evidence deployed by clinicians who use their clinical judgment and take into account the patient's values and circumstances. Since there's no clear amount of evidence yet discovered for some pediatric surgeries, we anticipate that some interventions may be unnecessary, conducted at an age where the conditions are likely to heal on their own, and that such excess could result in the children undergoing needless surgery and being exposed to unessential risks. So in this paper, we focus on the mismatch between evidence-based management recommendations and the practice patterns for hydroceles, umbilical hernias, epigastric hernias, and dermocysts, all in the pediatric patient department. So since there are no current guidelines for when and how to treat these conditions, physicians are left to ultimately choose the best approach. Now, the way we conducted this search was by doing a rapid review of several articles. What exactly is a rapid review? Rapid reviews are used to simplify data in a time-efficient manner by simplifying elements of the systematic review process. So over here, we took 3 main factors into account. 1, the surgical candidates. 2, the timing of surgery. And 3, the justifications for the chosen management. Now I will present some examples of some management controversies we came across through the literature. So for example, for hydroceles, Smith et al. Noted that the benefit of repair in potentially reducing testicular temperature and thus improving fertility is supported by some surgeons, but remains unproven. This statement was disputed by several other papers. For example, Pilatov et al. Mentioned that hydroceles on its own seem to have no direct effect on later fertility. Now, moving on to another example about epigastric hernias, Babsale et al. Noted that epigastric hernias represented about 4% of all abdominal hernias in children and require repair. This statement, along with many others, does not take into account that there are many clinical implications of anesthetic neurotoxicity, suggesting parents and providers should carefully consider the risk of anesthesics on the developing brain in the child under 3 years old. Now, onto the last example covering dermoid cyst, Cavanza et al. Suggested that the best management for dermoid cysts remains total removal. This statement can be contradicted by a survey taken by many doctors where they concluded that dermoids are considered by many ophthalmologists as benign, non-invasive lesions that rarely produce damage to the orbital structures. Now, taking all these points into consideration, our goal with this paper is to put to light how little guidelines there are towards these 4 conditions and how many surgeries are being performed without any evidence backing them up. That's the end of my presentation. You guys are welcome to ask any questions.